Hello, I'm Eytan Stein, and I'm a leukemia physician at Memorial Sloan Kettering Cancer Center in New York City. And today I'm going to be talking about whether the combination of the IDH2 inhibitor enasidenib and azacitidine given sequentially improve outcomes in older patients with IDH2 mutant acute myeloid leukemia. The answer to this question is a little bit challenging because we don't have randomized phase 3 data yet. But in the clinical study that I presented this year at the 2020 ASH annual meeting, I think some preliminary evidence suggests that using enasidenib with risk-adapted addition of azacitidine is potentially a therapeutic approach that will benefit our patients. So what do I mean? So we looked at a group of patients with newly diagnosed IDH2 mutant acute myeloid leukemia who had not previously been exposed to any therapy because they were newly diagnosed or any hypomethylating agent for myelodysplastic syndrome. And we asked the question, if you give these patients the IDH2 inhibitor enasidenib as monotherapy, and you look and you see if they go into remission, and if they don't go into remission after 5 cycles of the monotherapy, if you add on azacitidine to the enasidenib, so now you've got the doublet of enasidenib and azacitidine, if you add that on, can you then get responses in the group of patients who didn't respond to monotherapy? The outcomes of this trial were quite interesting. In the group of patients who received monotherapy with enasidenib, that was about 60 patients, approximately 50% of them had a response, with most of those responses being true complete remissions. There were 17 patients out of that original 60 who didn't respond to enasidenib monotherapy. And because of that, we added on the hypomethylating agent azacitidine. And in that group of patients, 7 of those 17 patients were able to reestablish a response or maybe get their first response with the addition of azacitidine. So I do think that this is an approach which makes a lot of clinical sense. That is, starting with enasidenib monotherapy, and if patients don't respond, adding on azacitidine and forming a doublet of enasidenib with azacitidine. I think there's a bigger question, and this would need to be answered in a larger randomized study, of what's sort of the best sequencing. So should you give enasidenib first, followed by adding on azacitidine? Should you give azacitidine first, followed by, and then adding on enasidenib? Or should you start both at the same time? And that's the kind of question that will need to be answered in a larger randomized study. Thank you very much for your time during this webcast.